when I'm evaluating a patient and considering whether or not I would like to undertake a therapy with them, um, I consider whether the patient might do better in a dialectical behavioral treatment, whether they might be better in a psychodynamic treatment like I provide. And so I think, different types of patients do better in different types of therapies. I think a one size fits all approach is usually unhelpful. And I think, unfortunately, a lot of people practice this way where we just go from diagnosis to treatment. And all of the other factors or variables don't really seem to matter when someone's thinking about what treatment a patient should receive.
Welcome to the Reality Therapy Podcast, where the truth will set you free.
Welcome. I'm here today. My guest is famous Hollywood actor Mark Ruffalo. And Mark, I have to say, I love your performance as the Incredible Hulk.
Ryan, you've got the wrong Mark Ruffalo. I'm sorry, man.
Well, I must have got my notes mixed up. I'm sorry. So you're Mark Ruffalo, the psychologist.
I am. I'm the therapist in Tampa, Florida. You should see the look that people give me when I make a reservation at a restaurant, and it's not the Incredible Hulk walking through the door. So yeah, no, I'm a psychotherapist, a clinical social worker down here in Tampa, Florida. Unfortunately, not the famous actor.
So with that, let's tell me who you are, what your background is, where you come from.
Yeah. I grew up in northern New Jersey. My grandparents were from Italy, and went to high school in Pennsylvania. Went on to college and graduate school at the University of Pittsburgh. Did an undergraduate degree in psychology and then master's degree in social work. And it was a strong psychiatric clinical social work program at the University of Pittsburgh. Was very lucky to land an internship with the psychiatry department at the psychiatric hospital, Western Psychiatric in Pittsburgh, and have established a career as a psychotherapist. I teach psychiatry residents psychotherapy, so I have faculty appointments in two psychiatry departments at the University of Central Florida and Tufts Medical Center in Boston. And yeah, that's a little bit about my background.
Nice. Okay. So you are more on the side of depth psychology, as I understand.
Yeah. So I'm very interested in psychoanalytic and psychodynamic approaches to therapy, which you know are I guess broadly we can contrast with the more symptom focused approaches like cognitive therapy and behavioral therapy, or cognitive behavioral therapy, or dialectical behavioral therapy, which are aimed at treating the observable manifestations or the symptoms of psychopathology. And so psychoanalysis or psychoanalytic or psychodynamic approaches are more interested in understanding what's going on beneath the surface, if you will, what's driving symptoms, what motivates people to do the things they do and to feel the things they feel. What about our development going back to our early life has influenced us and shaped us in terms of our personalities, and so psychoanalysis is it's a very classic approach to therapy going back to Freud in the late 1800s, and it was really quite popular in American psychiatry for a good 50, 60, 70 years there. And then the field shifted in the direction of psychopharmacology and more symptom focused approaches to treatment. And so a lot of young therapists these days don't really learn a whole lot of psychoanalytic theory. They may touch on it here and there in graduate school, and certainly at the undergraduate level, if you went to a more scientific, quote unquote, psychology program as an undergraduate, you might get very little in by means of exposure to psychoanalytic approaches, and much of what's taught by psychology professors these days tends to be pretty critical of psychoanalytic thinking. So yeah.
Yeah, it seems kind of bizarre to me because, well, I would say that I've missed out on a lot of education of what I'm supposed to be getting. But in terms of just like the psychoanalytic, you hear a little bit about Freud and maybe something about, the ego and the id and the superego and something about penis envy. And, by the way, he was on cocaine. And I learned nothing about Melanie Klein or self psychology or Nancy McWilliams. Like that was just I had no clue. I had to learn like that stuff on my own. And it seems like there's a huge history of depth psychology and psychoanalysis that we're just not passing on to the next generation of therapists.
Yeah, that's very true, unfortunately. And to understand why that's the case, you've really got to understand a little bit of history. And so psychoanalysis was never terribly popular in psychology. For the vast majority of psychoanalytic history in the United States, in order to train to become a psychoanalyst, you had to be a physician. And so if you were a psychoanalyst in the 50s or the 60s or the 70s, you had gone to medical school. That was a requirement to be admitted to a psychoanalytic training program. The psychologists saw themselves more, at least initially, as laboratory scientists, and they came to the practice of psychotherapy actually after other non-medical professionals began practicing therapy. So I often like to say that clinical social workers, they were then called psychiatric social workers, were actually the first non-physicians to practice psychotherapy, I believe at the Boston Psychopathic Hospital in the 1910s. And so for many, many years, if you were training in psychology, psychoanalysis was not really because it's hard to study empirically. A lot of psychologists really were quite disinterested in Freudian ideas and the like, and so. Yeah, there's a fascinating history there of the evolution of psychoanalytic thought. I think a lot of people these days, they hear psychoanalysis and of course they think Freud. And while Freud, of course, is the father of psychoanalysis, he coined the term and the model and method of working in therapy. To talk about psychoanalysis as if there's, basically it has not evolved since Freud is really to make an egregious error. There have been many, many adaptations to psychoanalytic thinking since the days of Sigmund Freud. Jonathan Shedler sometimes talks about the Freud as the horse and buggy era of psychoanalysis, right? I mean, we're talking about, cars. We're not talking about the Model A or the Model T anymore, unless you're a historian or something, right? And so it doesn't make any sense to talk about, id, ego, and superego very much anymore. Of course, there are some psychoanalytic theorists and the like who still incorporate some of those ideas, but the field has shifted and evolved in many different directions. And so I like to say that, when we say psychoanalysis, it can mean any of a host of things these days, from, classic, drive theory or ego psychology, object relations theory, psychoanalytic self-psychology, and some of the newer relational and intersubjective models. It's a very rich area of psychology and mental health that unfortunately graduate students and especially undergraduates aren't exposed to really at all. So much of the training in psychoanalysis and psychoanalytic modes of thinking occurs outside of formal training in mental health. So you have to enroll in a psychoanalytic institute, or gain exposure in other ways. And so there's interesting history there as well. There's only a handful of psychoanalytic training institutes that are affiliated with universities. Columbia University has one, Emory University in Atlanta has one, but most psychoanalytic institutes developed separate from universities, and so that's also limited the influence of psychoanalysis historically in formal education in social work and psychology and the like. So most of the great psychoanalytic thinkers throughout history, up until roughly 30 or 40 years ago, were psychiatrists. They were medical doctors. And then there was a shift beginning in the 80s when the American Psychoanalytic Association was sued by the American Psychological Association so that psychologists could begin training in psychoanalysis. And then you see clinical social workers and now mental health counselors, marriage and family therapists, and others going into psychoanalysis. So that's a little bit of the history and historically why psychoanalytic ways of thinking are not necessarily taught very widely in graduate programs these days.
Yeah, I want to focus in on something you said a couple minutes ago. Something I think the phrase was psychoanalysis is hard to get empirical evidence on.
Yeah.
And so your CBT type of people would say, this is the gold standard because there's a mountain of evidence supporting it. And one of the things I hear Dr. Shedler say is like, what counts as evidence? What do you mean by evidence? Why is it so hard to understand, what's the best approach between different modalities?
Yeah, I mean, I think there's a few common errors, I think, in thinking about what um, provides evidence for a theoretical model or approach to psychotherapy. If we look at outcome data, there's good empirical support for psychodynamic treatments as evidence-based therapies. And Dr. Shedler actually has done a lot of this work. His very influential 2010 paper in the American Psychologist really, I think, established psychodynamic therapy as an evidence-based treatment. So when you look at the treatment of specific forms of psychopathology, such as borderline personality disorder, which I take an interest in, you will see that psychodynamically informed treatments like transference-focused psychotherapy and John Gunderson's good psychiatric management are evidence-based treatments that are on par or better than other forms of therapy for the treatment of these conditions. So if you look at outcome data, psychodynamic therapies, depending on the type of disorder you're looking at, are just as good, if not better, than other approaches to therapy. I think what a lot of people criticize is the fact that a lot of psychodynamic ideas are hard to operationalize and they're hard to study because you can't really run a randomized controlled trial with a group of patients who are subjected as children to a certain type of environment, follow them longitudinally, and then have a control group. And so you can't really study these things in the way that the cognitive scientists and some of the others in different areas of psychology are able to operationalize their ideas. And so I think for that reason, I think the field of psychology in particular has been very cautious. Now, there's a lot of work being done recently by Mark Solms and some others who are in the area of neuropsychoanalysis to really study psychoanalysis more empirically, and I think they're doing good work. We have a lot of evidence from the attachment research literature that supports core psychodynamic principles and the like. So I think that you mentioned that the term gold standard, which really does frustrate me sometimes because I think people throw that around. It's more of a political term than a scientific one. And I think what people really mean when they say gold standard is, we have more studies supporting our method. And I think this is another common error, right? If you error is if you have two treatments and one has 10 studies supporting its utility for a particular disorder, and another treatment has 50 or 100 studies supporting its utility. We ought not assume that just because one treatment has more studies that it is a better treatment. Actually, when you look at the data, both treatments are effective. I think what gold standard often means is that we've got more funding, we've run more studies because we've been able to obtain more funding for our method because it's what the insurance companies like and for other reasons. And we say it's the gold standard because it's been studied more regularly. And so I think that's another common mistake that people make.
So you brought up attachment theory, and that's an interesting one. That's a big hot thing in, kind of pop psychology world right now. How much of attachment theory is hype and how much of it is legitimate?
Yeah, I think attachment theory is very useful. It goes back to work in the 1950s by psychoanalytically minded psychologists, actually. I think that a lot of people like to talk about attachment without realizing um, how connected these ideas are to psychodynamic theory. And so it's one thing to talk about attachment as an important way of understanding how human beings develop and sustain relationships. But if you're talking about attachment as if it's something divorced from the rest of psychological theory. And for instance, if we talk about attachment styles, we don't need to talk about personality structure, or personality disorders, then you're thinking about attachment all wrong. Attachment theory may help inform our ideas about personality structure, personality pathology, but it cannot and should not replace those ideas. And so I think attachment theory provides a very useful lens through understanding um, how human beings develop relationships, but it's incomplete, would be the argument that I make if we divorce it from the rest of our understanding of human personality.
Hmm. So I want to get into BPD a little bit because you've done a lot of good work on that. But first, I want to say I tell people that I have a controversial therapy podcast, and people go, "What could possibly be controversial about therapy?" But I want to say, I think it was a couple months ago, you had posted a paper on X, and it was something about how psychodynamic was equal or better for treating BPD compared to DBT. And I wanted
Mhm.
to duck for you. I was like, "Oh, he's about to take some shots here." Tell me about like that type of comparison of psychodynamic versus DBT.
Yeah. So we're talking about borderline personality disorder, which is a severe form of personality pathology. And so I was actually referencing, I think, the American Psychiatric Association's most recent treatment guidelines for the treatment of borderline personality disorder. And the treatment guidelines basically list several different effective therapies for borderline personality disorder. So when I was in graduate school and as an undergraduate, if the patient had BPD, um, there was sort of an immediate sense that we have to refer the patient for DBT. That was the first treatment that was considered, um, and um, and we now know, 15, 20 years later, that DBT is only one of a number of treatments that are helpful for patients with borderline personality disorder. In addition to dialectical behavioral therapy, we have transference-focused psychotherapy, which is a psychodynamic or psychoanalytic approach developed by Otto Kernberg and Frank Yeomans in New York City. And transference-focused psychotherapy, as the name implies, focuses on the relationship between the patient and the therapist, the transference onto the therapist, analyzing, understanding, interpreting the patient's characteristic defenses, which are projection, projective identification, denial, splitting, etc. And so you've got transference-focused psychotherapy. You have mentalization-based treatment, which was developed by Fonagy and Bateman in the UK, which is another psychodynamic model and approach to borderline personality disorder, very much influenced by some of the attachment literature and findings. And you also have John Gunderson's good or general psychiatric management, which is also a psychodynamically informed approach to treating the borderline patient. Gunderson was the psychiatrist who basically defined borderline personality disorder and got it into DSM-3 in 1980. He's widely considered to be the father of BPD. He developed his own theory of BPD and method of working with borderline patients, focusing on their innate interpersonal hypersensitivity, and developed a model for working with these patients as well. So the APA, publishes treatment guidelines, and they basically said that, well, there's a variety of different treatments that are effective for BPD, and so I think to focus exclusively on DBT in training programs and in hospitals and the like is really not giving credence to the array of different approaches that have been shown empirically to be helpful for these types of patients. And so when I'm evaluating a patient and considering whether or not I would like to undertake a therapy with them, um, I consider whether the patient might do better in a dialectical behavioral treatment, whether they might be better in a psychodynamic treatment like I provide. And so, I think, different types of patients do better in different types of therapies. I think a one size fits all approach is usually unhelpful. And I think, unfortunately, a lot of people practice this way where we just go from diagnosis to treatment. And all of the other factors or variables don't really seem to matter when someone's thinking about what treatment a patient should receive. Other factors like level of functioning and the severity of the condition, intelligence, what the patient is looking for, past treatment failures or successes. If you've had someone in DBT 3 times and they failed, they have not done well in DBT, well, maybe we should try a different approach. And so, anyway, yeah, that was a little bit of what I was referencing, I think, in the post that you mentioned.
So this is how I kind of conceptualize it in my mind. Tell me if you think this is accurate. So if the person had a physical wound, DBT is kind of like a very sophisticated band-aid or like an analgesic that kind of covers up the pain. And psychodynamic would be like, let's do surgery and kind of heal the deeper wound. I'm wondering, like, A, do you think that's accurate? B, how much ability is there to kind of change this core kind of personality dynamic within a BPD client?
Yeah, I think that that's roughly accurate. I wouldn't push back too hard against that conceptualization there, Ryan. I think it's probably true that DBT is a more superficial treatment in the sense that it focuses mainly on teaching skills and techniques to help with emotion dysregulation, which Marshall Linehan saw or sees as the core problem in borderline personality disorder. Now, I don't see it that way. I think emotion dysregulation is a symptom of other problems in BPD. I would roughly agree with what you were saying there. In terms of like prognosis, the natural course of borderline personality disorder, meaning, what happens to patients if they're left untreated? And we now have, 30, 40, actually 50 plus years of data on the natural course of borderline personality disorder. And it's actually improvement over time that when you look at the data from McLean Hospital and some of the other studies that have been done, you see that roughly 2/3 of patients seem to get a lot better, or at least somewhat better over time. These are, I'm talking about the natural course, patients who may not have been treated. Um, and about 1/3 of patients continue to struggle. And there's symptomatic improvement over time. The interpersonal life of the patient does often remain quite unstable. And so Mary Zanarini's work at Harvard has supported a lot of these ideas about natural course. So I think it's a very unfortunate misconception that the patient with borderline personality disorder will never get any better and that they have a progressive deteriorative condition that only gets worse in time. Some patients may have a worsening course, but in general, patients with borderline personality disorder get better. And when they're in therapy, when they're in good therapy, they tend to get better much more quickly. And does that mean that, life becomes a rose garden, to quote an old book? No. Often patients continue to struggle, and especially in the interpersonal domain, relationships can be quite fraught and intense and difficult. But a lot of the self-harm, a lot of the suicidal behavior, um, a lot of the instability and chaos in other parts of the patient's life, it seems to burn out over the course of 10 years or so. And so a lot of patients who meet criteria for borderline personality disorder when they're 20 or 25 no longer meet the criteria when they're 40 or 45 or 50. Some of them do. And for some patients, again, they continue to suffer well into adulthood and into their elderly years. But for the majority of patients, improvement occurs. And so I think that that's a very, very important idea that there's often a lot of misconceptions about. I think it's probably attributable to issues with cross-sectional exposure, meaning a lot of people develop their ideas about what BPD is by seeing patients at a single point in time. And they don't follow patients for years and years and years, like you do when you're doing long-term psychotherapy, like I do, or if you're running a longitudinal research study where you're following patients. Some of the best longitudinal data, by the way, comes from the psychiatrist Michael Stone, who followed some patients in New York City over 50 years. Some borderline patients he followed up with by phone once or twice a year over the course of 50 years and wrote a very good paper on following borderline patients 25 to 50 years later, if you want to Google that, Michael Stone. And he showed that many patients recovered. And so a lot of misconceptions about natural course and history and the prognosis of borderline personality disorder.
So I want to ask a question about how you as a therapist manage countertransference around BPD clients. Because in my experience, both as a clinician and a mental health tech, a lot of times it feels like everything's a level 10 emergency, and it's difficult to keep my own level of activation under control. How do you deal with that population?
Yeah. I think I would refer your listeners to the wonderful writings of John Gunderson in this regard. Again, Gunderson was the psychiatrist who really pioneered the diagnosis and has written extensively not only on the descriptive psychopathology of BPD, but also about psychotherapy, um, and also the writings of Otto Kernberg, who is a great psychoanalyst who's still teaching and writing. I actually just spent a year in a seminar with Dr. Kernberg, and so. But in a nutshell, I think it's really important to understand that these patients have a really unique and uncanny ability to stir things up within us, to make us feel uncomfortable, to make us feel angry. Um, Very famous paper from years ago, Hate in the Countertransference. Um, and um, and that this is very common for this population. Um, this is a core part of the problems that they bring into every human relationship. And if you can understand that, if you can understand that there's something happening here between us that reflects the problems that this patient brings to each and every one of their intense relationships of a certain proximity, then you can begin not to take this too personally. And you realize that what you're feeling is important because it's informing you of the patient's tendencies and characteristics and symptoms as they play out in other areas and other parts of the patient's life. And so Harold Searles was an analyst years ago who wrote a lot on countertransference and became very widely known for his writings on countertransference and how the therapist or the analyst uh, ought to use his or her countertransference feelings and reactions to inform the treatment. And so I think it's useful information. I remember, being in graduate school and sometimes countertransference, if it was covered at all, was covered as if it's a bad thing. Oh, you're having a countertransference. If it's something to be avoided, well, countertransference can't be avoided any more than any other feeling that we have can be avoided. It's very much a part of the daily work that we do. And so when I supervise psychiatry residents and I ask them to talk about their countertransference, some of them may say things like, "Well, I'm not having any countertransference." Well, that's a myth. You are having some reaction to the patient. Even that reaction is a reaction to the patient. Maybe it's boredom, or maybe you're not feeling anything when you're sitting with the patient. So, well, hopefully I answered your question there, Ryan. I
Yeah,
went
yeah,
off in a few different directions, but
yeah.
yeah.
Do you notice a difference in the manifestation of BPD between male and female clients?
I do. This is an important area. When you look at data in the community, borderline personality disorder seems to occur roughly as often in men as it does in women. However, in clinics, in practice, women are diagnosed somewhere on the order of 2 to 1 or 3 to 1. And I think that issues. There's a few different issues. One is the nature of the pathology may differ between men and women. Men may appear more narcissistic, or they
Mm,
may appear more psychopathic in their personalities, when the real pathology is borderline personality disorder.
mm,
Um, Women may have a more classic borderline personality disorder presentation. So I have a tendency to think that a lot of men with borderline personality disorder are misdiagnosed as either having narcissistic personality disorder or antisocial personality disorder. And that explains part of the discrepancy in the data from clinical practice. When you do community samples, you see roughly 50-50 split in who has BPD. Um, and so, I think it's probably true that your average male patient with BPD may seem you may find yourself being a little bit confused as to whether this is a borderline pathology or a narcissistic pathology. And that may have, again, something to do with with the diagnostic criteria's ability to capture male borderline personality disorder. And it may be better at capturing BPD in females. I think the idea that BPD is some disorder that occurs only in females or is an only female disorder has long been dispelled by people who actually know the literature and who study these things. Um, and so I think we have enough data now to support the idea that it occurs roughly equally in men and women. It may present somewhat differently, though.
Tell me if this is accurate. This is kind of what's coming up for me. Would you say that there's like a similar core emotional instability, but with women, they're more likely to try to protect that emotional instability with "I need you to feel sorry for me" or feel sympathy, whereas a man is more likely to try to project power so that you feel respect for me. Does that make sense?
That may be some of where the confusion is from. The latter there, the male example that you're using might get confused with narcissistic pathology. When and so there's a lot of overlap between the two constructs. And so let me just say a word about that. I think it's really important, and there's a lot of misinformation on the internet about it. Um, Narcissistic personality disorder was set to be eliminated from DSM-5 when the personality disorders work group came together because it lacks discriminant validity. And this is a long-standing problem. Researchers have known this for a long time, that you have a really hard time discriminating NPD from other forms of personality disorder. What do I mean by discriminant validity? I mean that this actually represents a separate disorder from other disorders. And so we see narcissism all the time in borderline patients. If we're talking about narcissism as a trait, um, we see narcissism throughout actually many of the DSM personality disorder categories. And so we will see what happens with NPD when we get to DSM-6 or whatever version of DSM comes next. It was one of a few personality disorders that was going to be eliminated because it lacks discriminant validity. That doesn't mean that narcissism doesn't exist. I don't want your listeners to come to that conclusion. What I mean is that when you look at the data, a lot of patients who meet criteria for narcissistic personality disorder also meet criteria for borderline personality disorder. And classically in psychoanalysis, at least some theorists like Gerald Adler and some others thought of these disorders as existing on the same continuum, that every borderline personality disorder patient actually has a narcissistic sector to
Mm.
their pathology. And he was one of several psychoanalysts who noticed that as borderline patients get better in therapy, they tend to appear more narcissistic, which supports this idea of a continuum between the two disorders, and that they may actually not be separate disorders. They may actually be the same basic pathology. In practice, though, how do we distinguish them? Um, that's a complicated question, but I think deficits in in the ability to hold and soothe oneself predominate in borderline personality disorder. I have a hard time holding and soothing myself when I'm alone, what John Gunderson called the intolerance of aloneness. Uh, Narcissistic patients have deficits in self-worth and self-esteem. So they rely on other people to sustain their sense of how good they are in the world, their self-esteem. Now, often you will see borderline personality disorder patients who have deficits both in holding soothing and in self-esteem. And so whether these are really two distinct disorders is an interesting question. And if you look at the data, NPD doesn't have good discriminant validity. We'll see what happens with the next version of DSM, and it will be interesting to see what the new task force ends up doing with it.
You talk about discriminating validity with NPD, and I wanted to bring up that similar topic with a different disorder that's highly debated right now, and that's complex PTSD. Is this distinguishable from PTSD? Is it trying to rebrand BPD borderline? What is CPTSD, and is it a good way to conceptualize something?
Yeah, complex PTSD goes back to the work of Judith Herman in the early 1990s. When Herman was writing, she was really writing about problems that really look and feel very much like borderline personality disorder. And so and actually, if you read Herman's writings and if you watch her lectures and the like, you will soon see that she was actually looking um, to do away with the borderline construct. She saw it as stigmatizing, not as taking into account the trauma histories of these patients and the like. And when we look at the data, patients with borderline personality disorder do have very high rates of childhood abuse, neglect, and other forms of mistreatment in early life. Now, the problem with complex post-traumatic stress disorder is also that it seems to lack discriminant validity when you consider the fact that what CPTSD may capture is actually what Mary Zannarini has called subsyndromal borderline personality disorder. So if you look at CPTSD as a construct, there's a lot of overlap with borderline personality disorder. What you don't see as much of is instability in interpersonal relationships. You see the construct actually, as theorized, actually says that patients with complex trauma tend to avoid relationships. Now, this is the exact same syndrome, more or less, that Mary Zannarini years ago described as subsyndromal borderline personality disorder, on the same continuum as BPD, but it doesn't reach the threshold for diagnosis of full-blown borderline personality disorder. And some people now, I believe, are calling this complex trauma. Now, even complex trauma researchers um, admit that that CPTSD and BPD may exist on the same continuum, with CPTSD representing the less severe form of the pathology, and BPD referring to the more extreme form or more severe form of the pathology. My problem, and I've written a little bit with Joel Paris in Canada on this, is that if we introduce CPTSD formally in the United States, it's already recognized overseas. If we introduce it in DSM, my sense is that a lot of patients with borderline personality disorder who would be referred to or for evidence-based therapies for BPD are actually going to be diagnosed or perhaps misdiagnosed with complex trauma and referred for vague and generic trauma therapies that may not target at all the core problems that we see in borderline personality disorder. I think there's an additional risk, which is that a trauma treatment may actually reinforce some of the patient's externalizing defenses, meaning their tendency to blame others and to blame the outside world for a lot of the problems that originate as a result of their own condition and behaviors. And so externalizing defenses are very common in BPD. And so if we treat the patient as if they're simply a victim of external circumstance and makes no contribution to their problems, their ongoing problems in life, then I think we risk really mistreating that patient, and we may actually reinforce the very problems that they bring into therapy. And so John Gunderson's written about this. Otto Kernberg has talked about the different countertransference reactions in therapists that may lead them to see the patient as a helpless, hopeless, sort of passive victim. The other problem with complex trauma, from my perspective, is that it fails to incorporate the genetic research on borderline personality disorder. We know the heritability of BPD is roughly 45 or 50%, going back to Torgerson's work in 2000, and now is well established in the BPD research community. We know that there's a significant heritability to borderline personality disorder, whether that's an innate aggression or interpersonal hypersensitivity. The child brings into the world a temperament that colors and may distort their perceptions, and it may influence the way caregivers and parents treat the child. As any parent will tell you, children differ in terms of temperament. They come into the world very differently sometimes than their siblings do. And so to put the focus on trauma as the sole etiological factor in borderline personality disorder, I think ignores the multi-causal nature of BPD: genes, temperament, early environment, biology, the patient's own constitution, and their own psychological makeup. Complex trauma has a way of flattening all of that and saying that you have this disorder because of trauma. And that's the only reason you have this disorder, which we actually know is just not true. It's just not empirically true. There's lots of variables at play in terms of understanding why a person develops BPD. Many patients, 80% of patients who have traumatic childhoods don't develop any psychopathology in adulthood. That's the work of Joel Paris. 20% do, but 80% of people who experience trauma in childhood don't develop any discernible psychopathology. And so I think complex trauma has a tendency to flatten all of the complexity that we know about human personality and human psychology. I actually have a paper in press now at the American Journal of Psychotherapy that touches on some of these ideas on avoiding oversimplification. I think there's great appeal to oversimplified narratives in therapy where we just want to say X occurred because of Y, or Y occurred because of X, when in reality things are much more complex.
Hmm. So you were a man in as a mental health professional in a field that's overwhelmingly female dominated, and I think that's brought a lot of good things into our field. But I wonder if we are also missing something about how we understand and conceptualize men's mental health. So in recent years, we've seen men start to drop out of the labor force, drop out of education. Addiction's on the rise, suicide is on the rise. What's going on with men's mental health that we're missing?
It's a really, really important question. Why is there a worsening in men's mental health, and why are men avoiding therapy? I can speak maybe to the latter more usefully than I can to the former. I think that there's a tendency among some men these days, I think, to see therapy as this warm, cozy, supportive, validating sort of endeavor. And that may not speak to what men want or need out of therapy. I think that some men want and need something that doesn't fit very well with that, without that type of conception of therapy where we're just warm and validating and supportive. I think some men are much more interested in understanding themselves more fully, maybe in a way that aligns with psychodynamic approaches, where they're interested not so much in those relational tones, but more in terms of understanding themselves intellectually. And so I recently, wrote something about this. Is I think there's been a shift in the past 40 years or so as the field of psychotherapy has become more heavily female. Um, Theories have evolved, and so when psychotherapy was dominated by men, it certainly had its problems, and it probably was far too interested in interpretation and the intellectual game of therapy, making sense of symptoms, delivering in interpretations, analyzing defenses or interpreting defenses. And now, especially in the psychoanalytic world, things are very much um, uh, have turned in a way that really places much less emphasis on those elements of therapy, and it's more of a feeling endeavor. And I think a lot of men really, they don't want to go into therapy for that type of therapy. That's what's observed on social media. That's what they get on YouTube and the like, and they just basically conclude this isn't for me. Either I want practical solutions, or I want something that's really going to help me understand who I am and why I'm struggling and the like. And so I think there's been a certain evolution in therapy itself within the field itself that has led men to avoid seeking therapy, as well as the fact that it's just plain hard to find a male therapist these days. I have a pretty equal split men and women in my practice, but a lot of the men I see me because in part because it's impossible to find other male therapists. It's really hard actually, for some men.
Why? So this brings up a natural lead into my next question. Why are men less likely to become therapists?
That's a great question. I think it may have something to do with what I was just speaking about. I think a lot of men years ago were attracted to psychotherapy. I can speak for myself. I was interested in psychotherapy because I was very curious about the workings of the human mind, um, of how the mind could become ill, of the nature of psychopathology, of what um, leads human beings to act in the ways they do and behave in the ways they do and to suffer in the ways they do. And part of the appeal to psychotherapy for me was as an attempt to make sense of the aberrations of the human mind. So early in my career, I was very much interested in schizophrenia. I had no personal connection to schizophrenia. It doesn't run in my family. I knew of no one with schizophrenia as a child, but schizophrenia is a fascinating condition. The way that a person can suddenly, when they're 18 or 19 or 20 years old, start hallucinating and become delusional and paranoid. There's something inherently fascinating about that pathology, about what happens. It's saddening and and unfortunate, but also fascinating and intellectually stimulating, I would say, for me. I think that a lot of men have seen a shift in the field away from the study of psychopathology and that way of understanding what's going on and the intricacies of the mind and how it functions and how it works to much different type of field these days, again, that focuses less on those things and more on feelings and emotions. Now, some people might, accuse me of intellectualizing here, and I probably do. It's probably one of my chosen defenses, and it is intellectualization. But I think a lot of men are this way. Men become engineers, they become scientists, and they become surgeons. We're interested in the technical aspects of the work. And so years ago, you would see males who would write books on psychotherapy technique, like Robert Lange's and others. And now a lot of what's written in the field has very little to do with technique. And so I think there's been a shift that sort of has occurred that may lead men of certain, of certain orientations to choose other fields that may be more scientific or offer them a better opportunity to make money, because it's become, at least in some areas and for some people, very difficult to make a good living being a therapist. Maybe that has to do with the saturation in the market. There's lots of forces, managed care, lots of variables at play, but it doesn't necessarily offer the most lucrative career choice, unless you go into private practice and you find a way to make a good living doing therapy. But the average therapist doesn't make what the average engineer makes, for instance. So I think there's been all sorts of changes over the years that have led men to avoid becoming therapists,
Hmm.
and other variables as well.
Hmm. What have you seen in recent years in terms of politics being injected into the field?
Yeah, I think this occurs pretty regularly. It's actually one of the things that attracted me to psychoanalysis, initially at least, was the idea of the therapist as not having any control over the patient. Glenn Gabbard has said that psychoanalysis is a non-coercive venture. Um, it appealed to my more sort of libertarian leanings, libertarian philosophically, I mean, where I wanted patients to be in control of their own lives. I wanted their autonomy to remain intact when I was working with them. And the idea of the analytic therapist being someone who could help provide some ideas and maybe some insights and interpretations that might help the patient better understand themselves. But my role was not to tell the patient what to do or how to live the patient's life. It's their life to live, it's not mine. And so that was really an appeal. I think what's happened as we've seen more of a political type of therapy develop, a social justice type of therapy, is that a lot of these um, uh, decades old ideas about the frame of the treatment and the role of the therapist in the treatment as not being someone who imparts their own way of living on the patient. I think a lot of this has gotten lost in the mix, where a lot of young therapists now see their role primarily as activist or advocate for the patient. Um, and they tend to see patients as victims of circumstance. And certainly people can be victims of various forms of oppression and trauma and neglect. I'm not negating or denying the fact that people can be victimized, but I think there's been sort of a pendulum that's swung completely in the opposite direction now, where there's been an intrusion of certain political values and ideas into psychotherapy. And I think that even if you're on the left, there's a recognition that therapy has evolved in this way. Now, you may not see it as a bad thing. You may see it as a good thing, but certainly there's been a change in time. And so, um, I'm not sure if I'm doing your question justice there, but there's definitely been a shift over time in how political therapy has become. I think in some quarters or corners of the field, it's much more visible and apparent than other ones. And this is why I've really tried to focus my own work and study and writing on psychopathology, on the treatment of specific psychiatric conditions and illnesses and problems, and not so much on some of the broader um, stuff that you see often these days.
Yeah, it seems to be a big problem kind of allowing our field to be perceived this way, both in reality and in perception, because I think mental illness is somewhat evenly distributed across the population, but it's starting to become culturally something to where therapy is something Democrats do and Republicans don't. I think you hear like Matt Walsh saying therapy is worthless, don't do it. You know what I
Yeah.
mean?
Yeah, I've seen some of Matt Walsh's stuff. It's actually really unfortunate that he puts out those messages. I think he's just wrong about it. But you're right. There's a certain cultural element to the whole thing. Depending on where you fall on the political spectrum, you may be more or less likely to do therapy. I think that's unfortunate because you can be on the right and suffer from the same ailments and same problems and conditions as someone on the left, and you may be less likely to get therapy because of it.
Hmm.
Um, and so I agree. There's a cultural element to the whole thing too.
Yeah. So I'm going to ask a question. It's going to sound weird given that we're 53 minutes into a conversation about therapy, but the question is, what is therapy? And the reason I ask that is because this has been bouncing around in my head a lot. You'll hear people say therapy is about insight, gaining some insight about yourself. No, it's about changing something in yourself. No, it's about changing a behavior or lifestyle. Then you have people say the gym is therapy, yoga is therapy. So what is I'm about to finish a master's degree, but I'm not sure I know the answer to that question.
It's a good question. I'm sure that the philosophers of psychology and the philosophers of mind and psychiatry debate this all the time. Um, Therapy, I suppose, literally just really means a treatment. You receive a treatment for something. So I've always framed psychotherapy as a treatment for some problem that the person is facing. Now, maybe that problem rises to the level of a psychiatric disorder or condition. Um, or maybe it doesn't. But therapy is a treatment. You go to physical therapy to ail an injury. What we call, medication therapy for a whole wide array of physical problems, and psychotherapy for treatment of disorders of the mind or problems of the mind. And so I see therapy primarily as a form of treatment, just like any other psychiatric treatment like medicine or electroconvulsive therapy or TMS. It's a treatment for a problem. Um, Now, beyond that, though, I think you're raising a bigger question, which is, what does it mean to be in therapy? Um, and I guess to that, I would say, um, that depends on what school of thought and what style of therapy you're practicing. Um, but from my perspective, therapy involves talking and listening, obviously, but listening in a way that is not the way a friend or a family member might listen to you, but in the way that a trained therapist listens, which is sort of non-judgmental, um, uh, unbiased. I think the contract in therapy is so important. It doesn't get talked about widely enough. And the contract is basically, the rules of the game for therapy. And so, some people may, be asking, or wondering, what's the difference between talking to a friend or my barber or the bartender about my problems and talking about and then talking to a therapist. And I would say the difference is the contract. Now, beyond that, of course, the therapist knows certain things and does certain things that your barber doesn't. Um, but the contract means there's rules to this arrangement. The therapist is going to do certain things that he or she promises to do, and is not going to do certain things that he or she promises not to do. And one of the most important things is confidentiality. And so when you talk to a therapist, you have the assurance that that therapist, if he or she is practicing ethically, is not going to be talking to anyone else about the things that you're telling him or her. Is not going to try to impose certain ideas or values, does not have a vested interest in you as a family member, is not going to simply tell you what you want to hear, for instance. And so therapy offers a relationship with someone, an opportunity to rework the way that you relate to people in life. It's a method of treatment, um, and is very different from any other human relationship for these and I'm sure many other reasons.
Hmm. I got two questions left for you, and the first
All
one is a
right.
softball. It should be really easy for you. If you could wave a magic wand, how would you fix the therapy profession?
Oh, geez. If I could wave, I have not really thought about this. Um, I, I, uh, I suppose I would say that that there ought to be more rigorous training in graduate school on issues of classification, diagnosis, and psychotherapy as a form of treatment and personality. Um, I think that now it's easy now as an outsider and someone who's been out of graduate school for quite a while almost 15 years, to say that, that training has gone downhill and all that, but there are others in the field. Otto Kernberg has said on record that, training in psychotherapy has gone down the drain in the United States. I think he's probably right. I think psychotherapy used to be a very rigorous discipline. It used to be something that was somewhat difficult to get into. Um, it was something that required you to have undergone your own treatment and your own therapy, at least for a period of time. Um, and now I think that training in the therapy professions has become less rigorous. I think there's a lot of focus on pretty extraneous ideas and theories that aren't really going to help the clinician in the room with the patient. And so a lot of what's taught in graduate schools really has very little to do with clinical practice. And I think that that's a big problem from my perspective. So I think an overhaul of the education system would be the way that I would answer your question if I had a magic wand.
I can attest to everything that you were just saying in terms of the lack of rigor and the poor preparation. I'm 100% in agreement there. Um, Final question is, when you look at society more broadly, what is one issue that we're not talking about enough that we should be talking about more?
Oh, that's another great question. Um, I think I'm going to come back to the issue of diagnosis here for a moment, and the affinity that so many people, especially young people, have for diagnosis. A lot of people don't know the history here. Diagnosis in psychiatry prior to DSM-3 didn't really count for much. You were either neurotic, psychotic, or somewhere in between, and then you were called borderline. After DSM-3 was published, DSM the DSM became not only a book for mental health professionals, it became a cultural, bestseller. People started to talk about what they were diagnosed with. And some people began to identify very closely with their diagnosis, with their label. And I think that this has come actually with great cost. Now, some might argue that it has helped with stigma, that people are now more open about their struggles. But I think that identifying very closely with a diagnostic label can cause a lot of harm as well. And so really, when you look at DSM, a lot of the things that people really most closely identify with are not very well supported, empirically validated disorders. And that's a whole other can of worms. There is how the DSM system has exploded, and we're calling a whole bunch of things disorders that really don't have much validity. And we've got a book of about 400 different diagnoses, and we really may have only 15 or 20 or so valid psychiatric illnesses when we look at classic criteria for disease validity in psychiatry. And so, I think the identification with a diagnostic label, and we can, we can attempt to understand why people do this, what it means. Why is it that some people cling very closely to diagnoses like autism and ADHD and the like, and others don't? I think there's a lot of rich psychology to this whole thing that ought to be understood, and people ought to write about it. But I don't think that this gets enough attention. I think that a lot of the attention is on the value in terms of decreasing stigma. And I think there's costs and harms associated with that whole phenomenon as well.
That is a fascinating answer. I love that answer. Well, Mark Ruffalo, the Hulk of psychoanalysis, we could say.
I don't know about that, but thank you.
Yeah, well, thank you so much for joining me. I really enjoyed this conversation.
Yeah, Ryan, it's been great. I really appreciate you having me on. Thanks so much.